There we go. Hello, everyone. How are you? Hopefully you can all hear me okay. Thank you all so much for joining us for this webinar today, where we discuss some of the more salient points of the AIS guidelines and how they relate to our practice. So I'm very pleased and honored to introduce you to Rhonda Finnie. She is our current ANVC president, and she's from Little Rock, Arkansas. She's got over 20 years of neurosurgery at Baptist in Little Rock, and she's a NetSmart graduate and holds two NVC3 certifications, the ANVP and the Advanced Stroke Coordinator. So without further ado, please, Rhonda, take it away.
Thank you so much, Lisa. I appreciate that. Many of us sort of met at ISC, and I was glad to see so many of my colleagues there. Some of you were not able to go, but I have no doubt that you are, doing the deep dive into the guidelines. And so again, I want to sort of provide some perspective on some of them and not necessarily read every single guideline. So what I have picked for us today are some of the more salient points, and some of maybe background and maybe perspectives, and so on based on the guidelines and the recommendations that are in them. I do not have any disclosures. I would love to have some, but I don't. So we will continue on. But I do want to briefly review the guideline development because I think that it has some impact on what is in the guideline. So I do want to briefly go over that. I also want to distinguish between living and dynamic and static guidelines with you that may be more relevant as we look around the globe at how other countries, how other organizations sort of complete their guidelines. And then obviously we're going to review the 2026 guidelines and really talk about stroke programs and the implications for them. In terms of guideline development, there is always a literature search for any guideline development. And in this particular guideline, they looked at very established, reputable databases that house a lot of high quality publications, PubMed, Cochrane, Medline, et cetera, and any of those articles that are published in English. The search was continued over about 3 months at the end of 2024 for relevant papers for evaluation since the last guideline. Now, I've been around a little bit. Some of you have been around a little bit less time. Some of you have been around a longer period of time with stroke guidelines. The last guideline came out in 2018. And if you recall, there was a very, very, very quick updated guideline in 2019, and there were publications with the extended window for thrombectomy that were published almost simultaneously in 2018 with the guidelines. And so as a result, we had to have that 2019 update reflecting those extended windows for thrombectomy due to the DAWN and Diffuse 3 trials. So this particular guideline included impactful papers, and they evaluated relevant papers for over 3 months up to March of 2025. So what that means is that papers that were published after that date were not included in the evaluation and into the guidelines. That's important because I know many of you and many of our colleagues were involved in the optimal head positioning before thrombectomy and large vessel occlusion stroke that was published in JAMA Neurology in June of 2025 with Dr. Alexandrov and colleagues in terms of zero head positioning. And so that was published after the deadline. And so I did have people ask me at the ISC, I don't understand why that wasn't included, and this is why. So it's really important that we understand that it was published after the deadline. Okay, so I just want to make sure, and especially as we go through the recommendations, we'll come back to this a little bit more. But this sort of goes into our definition of static versus living guidelines. In the United States, we have guidelines that we sit down at one point in time and we evaluate the evidence, just as I've described, and we evaluate it and we evaluate the previous guidelines and what do we need to do differently? Do we need to upgrade the recommendation? Is there a different level of evidence that we need to sort of indicate on the guideline? And those are done, 5 years usually. And so those are very static guidelines. And so in the United States, that's the structure that we have chosen to do to evaluate and to make recommendations, knowing that we did so much in the last 5 years, and some of that we've already incorporated into our practice. TNK is one of them. If you look at Australia as an example, Australia uses living guidelines. So instead of at a point in time, they really look at evidence as it comes out, evaluates it. Do we need to change our practice now? And they change their guidelines in a much more contemporaneous scenario. And so what that allows them to do is it allows them to stepwise, allows them an incremental approach to changing guidelines rather than having a big document that now we have to sort through and think, how many things do we have to change? So I just want us to recognize that not everyone around the world looks at guidelines at a point in time, and I think that there is some benefit to looking at guidelines in much more of a contemporaneous way, and allowing us to absorb the changes that we need to make in practice gradually. So again, Australia, the difference between static versus living guidelines, and that may come up again in the future as we look at how should we really approach guideline development in the future. Getting into the guidelines, we have some pre and inter-hospital considerations in this particular guideline. Mobile stroke units have demonstrated benefit over conventional systems, and have demonstrated that in multiple studies. There have been challenges to the mobile stroke unit implementation around, particularly in the U.S., sometimes due to reimbursement, and just staffing the MSU. But in the guidelines, it clearly gives a recommendation and indication that the MSU does provide benefit. We knew it did, but now the guideline says it. And so hopefully we can have some more discussion about the MSUs and how they're utilized and getting them paid for what they do so that they can continue to provide a very quick evaluation and thrombolytic treatment very close to the patient. Destination routing and management has been a hot topic for a long time. The previous recommendations in the previous guidelines were for the nearest stroke capable facility because we don't want to lose an opportunity for thrombolytics. But we know that even in areas where you can get sort of a fast thrombolytic treatment, those patients who really needed thrombectomy were limited in terms of where they could go. And if you're in a state like mine, you can only go a few places. And so we had door in, door out challenges. And I know I'm speaking to the choir when I talk about this. It's not that the acute stroke ready hospitals do not want their patients moving to a higher level of care. We have constraints in the comprehensive centers. In rural areas, you may only have one EMS, or if you have more than that, maybe you have to leave one in the county. You can't have them both out. And so there are many, many challenges to that. One of the more validated instruments to use for systems, and not just hospital systems, entire inter-hospital system of care, a validated tool that has been shown to really identify where the areas are for improvement is that SWIFT instrument. And that was published in Stroke Clinician. It was by Dr. Jennifer Patterson and colleagues, which is a really good tool for you to be able to identify where is your bottleneck in terms of getting door in and door out, and getting that qualified and quantified, actually. So I would encourage you to go back and look at that instrument. If you're looking for ways to improve that door in, door out, you have to figure out where your bottlenecks are and go from there. In this particular guideline, now we have consideration of the characteristics of the local systems of care. The systems of care in some states, because they have unified EMS systems, is very different than where I am, where you're trying to get, dozens of EMS services on the same page. They all want the same thing, but trying to get them on the same page. And so now there is recognition that that you might want to carefully consider direct transport to an endovascular capable facility and systems that do not have a rapid interhospital transfer, especially for patients with large vessel occlusion, and paying attention to the eligibility for IV thrombolytics. If you have a well-coordinated system, interhospital transfer process, then maybe you can get treatment where you need to and know that you can get them out very quickly if you have these agreements that's not dependent on, do I have a bed? Maybe they have a bed always available for that stroke patient. And again, in the guidelines, systems should prioritize transfer for acute stroke patients requiring a higher level of care. That needs to be heard by our administrators when they're saying we have no beds. And well, if you only have 3 thrombectomy capable facilities in your state, where do patients go? And so again, recognizing that this is a more than just a one hospital issue, and we know it is. And again, I know I'm speaking to the choir, but I was very happy that this language ended up in the guideline. When we talk about thrombolytics, many of us have already transitioned to tenecteplase in the 4.5-hour treatment window. And so there is language for tenecteplase or alteplase in the 4.5-hour treatment window. This is an example of a practice that we already, that many of us already assumed prior to this guideline coming out, when tenecteplase was found to be non-inferior to alteplase. I want to reiterate, I just had this conversation with actually one of my colleagues who was evaluating a patient with a low NIH. And she said, I had to remember that I needed to look at what is disabling to the patient. And always remembering that thrombolytic treatment in eligible patients with disabling deficits should be considered regardless of the NIH without advanced imaging. So don't waste time on the CT if you have a stroke patient with stroke symptoms that have a low NIH, but it's disabling. Some things are clearly disabling. If they can't speak, if they have aphasia, that's very clearly disabling. But some of them may be a little bit more subtle. And the guidelines really has a very good, I thought, a very good table on sort of distinguishing between the two and just having us consider the fact that what we find disabling might not be to someone else, and what might not be disabling to me might actually be disabling to someone else. Patients with non-disabling symptoms, those example will be those pure sensory lacunar strokes within the 4.5-hour window, have not shown improved outcomes with thrombolytics. And so again, this is not a reason not to treat. One of the things that I really thought was an improvement in this guideline over the previous guideline was that it gave you the guideline and then gave you a whole lot of stuff to read at the bottom of it. And I thought it was a little bit more expansive as well. The window for thrombolytics in some patients who wake up with stroke symptoms might be within 9 hours or 4.5 to 9 hours from last known well onset using advanced imaging. So perfusion studies showing salvageable ischemic penumbra, those patients might be considered for extended window for thrombolytics. Patients with sickle cell. Again, IV thrombolysis can be considered without additional safety risks in those patients. And then the central retinal artery occlusion. There are some defined prerequisites for some of those, for some patients presenting with that. And obviously making sure that there's nothing else going on with that patient, whether it's a retinal detachment, giant cell arteritis, and having that risk-benefit conversation with that patient. There's an extensive table also in these guidelines where eligible patients, the benefits outweigh the risks. There's some relative contraindications, there always are, and there's some absolute contraindications in that particular table. When we look at endovascular therapy, there has been for some time discussion about expansion of those endovascular therapies to populations that we would not have offered an intervention to previously. Those are patients with the larger core infarcts and lower aspect scores. And again, if you recall, aspects is the Alberta Stroke Program early CT score. Perfect score is 10, and you subtract a point for every abnormality in different areas of the brain. So lower aspects, less than 3, are now considered candidates in some respect for endovascular therapy. Again, a pre-stroke modified Rankin score of 0 to 1 also was a consideration as well. There's a strong recommendation for endovascular thrombectomy for patients with basilar artery occlusion who present within 24 hours with an aspects of greater than or equal to 6. So they have some abnormality. It's more moderate changes, and an NIH score of greater than 10, so a little bit more severe presentation there. There's an entirely new section on pediatric patients. We are fortunate to have a children's hospital right down the road from us. And so all of the pediatric patients go there. But you may be in a facility that treats pediatric patients. And so there are recommendations related to endovascular therapy as well as thrombolysis for those patients. I always find recommendations with credentialing interesting in the guidelines. We would think that this would go without saying. I review all the credentialing applications in our organization for advanced practice. And so making sure that people are trained and making sure they're educated and then demonstrated the education is also very important. Especially there are different pathways to this endovascular practice for physicians, and I always think it's interesting that it shows up in the guideline. What I would encourage all of you who are in advanced practice, I'm a NetSmart graduate. I'm not faculty for NetSmart, but I will tell you, I would have never been as knowledgeable on my own as I was when I completed the program and sat for my ANVP exam. I think that gave me a lot of confidence. It definitely gave me a lot of credibility with my colleagues in doing that. And so again, paying attention to our education is not just for the physicians, it's also for us as well. So I just would encourage you to think about that. Blood pressure management after thrombectomy. There has been so much sort of conversation about where should it be? Should we normalize it, especially if you get a high-grade reperfusion? So you get a TQ2B, 2C, 3 perfusion. And what the guidelines suggest now is that this intensive blood pressure control to less than 140 is not recommended. It wasn't associated with improved functional outcome in patients with mild to moderate stroke severity. Your really severe strokes, where you have a lot of damage, a lot of hypo density on the CT. You might be worried about hemorrhagic transformation with those patients. But again, now we have to have a conversation about where does the blood pressure, where do we put it? And again, there are, in terms of antiplatelets, dual antiplatelet, we've been doing this for some time with clopidogrel and aspirin for 21 days, followed by single therapy with minor non-cardioembolic strokes or high-risk TIA within that 48, 72 hours of stroke onset. Okay. Again, those are patients with presumed large artery atherosclerotic etiology of stroke. So those are recommended for those patients. And there's an extensive sort of commentary on antiplatelet agents for these patients. There was some sort of suggestion that maybe IV glibenclamide, which is glyburide, trade name, in patients with large hemispheric strokes, that it might be able to abate some of the cerebral edema. But this particular guideline on review of the evidence showed no benefit in functional outcome with that strategy. I'm going to spend a little bit of time with head of bed positioning because the guideline, and we're going to talk a little bit more about this. The guideline says there's no benefit in routine 0-degree head positioning compared to 30 degrees in the first 24 hours to improve outcomes. And a corollary to that is no benefit in the negative 20-degree Trendelenburg positioning compared to 0 to 30 degree head positioning in large artery atherosclerosis. So I wouldn't want to put my head down at negative 20 degrees. I don't find that comfortable, and I'm sort of a healthy person, so I can't believe that anyone would find that comfortable, but there's no benefit in doing that Trendelenburg positioning. I do want to talk about this quote unquote routine 0-degree head positioning compared with 30 degrees. I want to talk about that a little bit more because of the findings in Zodiac. And many of us were there in, I believe it was 2024, when we were at the ISC, where main podium, very exciting results. And many of us have sort of changed practice because in that patient population, and that's really important, while they're waiting on definitive treatment as sort of a bridge to that treatment. The head of bed positioning, the evaluation was really sort of based on three different things. The head post trial was an international cluster randomized crossover open label trial. It enrolled all stroke types. And I think we can all look at the hemorrhagic stroke patient is not the same as the ischemic stroke patient, is not the same as the large vessel occlusion stroke patient, et cetera. And so they enrolled any stroke type to receive the intervention in a randomized way. Many of the enrollees had minor strokes, so you would think that maybe a head of bed positioning might not be as effective in showing a demonstrated benefit. And then in many of the patients, there was a delay of intervention by several hours. And so it was a very, the heterogeneity in the population is not quite as tight as you would want it to be. But regardless, in this particular study, there was no benefit in that 0-degree, but I think there are reasons for that no benefit. There are limitations to it. There was an additional phase 2B trial that looked at really measuring the mean flow velocity in the ipsilateral MCA at 0 degrees. Okay, so there was this particular trial showed there was an improvement in the velocity, but there was no difference in outcomes at 90 days. The HOPES-2 trial looked at that negative 20-degree Trendelenburg position with a probable larger artery athero and eligible for other treatment, and did not find any benefit there. Okay. So before I go to stroke units, what I would say is um, read that fine print. Many of us, again, have changed for the large vessel occlusion patient. So I would just encourage you to read the fine print and really read that and have some thought before when you are looking at doing a head, sort of making recommendations in your own institutions about head positioning. I do want to say something about stroke units. If I have been part of the faculty for ANVC for the review series for the ASC, for the ANVP, for the NVRN, and we always have a section on stroke units because in the United States, our what we call as a stroke unit looks very different in other parts of the world, in Europe, Australia, and so forth. And so in the United States, the 2018 guidelines said the use of a comprehensive specialized stroke care, and then it had stroke unit in parentheses, that incorporates rehabilitation is recommended. And that's all it said. And so there wasn't a discrete sort of geographical location of a quote unquote stroke unit in the United States in terms of the guideline. The 2026 guideline says this: treatment within an organized inpatient stroke care unit supported by specialty trained interdisciplinary care team, blah, 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 that incorporates standardized stroke care order sets and protocols is recommended to reduce the odds of poor outcomes and death. And so what this means is that an organized inpatient stroke care unit is now being clearly identified in the guideline. And that's important because now we need people who are going to be specialty trained in treating stroke. The therapists are going to be there. The physiatrists are going to be there and so forth. And so I just want to show you the difference in the language between the previous guideline and the 2026 guideline. The benefits of stroke units were strongest in geographically co-localized units, and that's a quote from the guideline. Okay. The stroke unit trialist collaborations published in 2020 and suggested that that patients who were treated in an inpatient stroke care unit by specialty trained multidisciplinary care teams were more likely to survive, more likely to be independent, and they're more likely to discharge home. And we see those outcomes in other parts of the world that really have well-organized stroke units. So I just want to really highlight the difference between these two things. Craniectomy. I come from neurosurgery. I've been a part of neurosurgery practice for over 20 years now, and practitioner for that practice. And so craniectomies were always, for us, in a non-academic center, were always a topic of conversation. And the 2018 guideline, the language was, and you can see the recommendation, the level of evidence there, that patients less than or equal to 60 with a unilateral NCA infarct with neurologic deterioration within 48 hours due to brain spilling, despite medical therapy, decompressive craniectomy is reasonable. And now the language you have is, well, it's a recommendation, one, level of evidence A is beneficial. And so the language is a little bit different, going from reasonable to beneficial. The language there is a little bit different for craniectomy. So I just wanted to point that out. It's helpful to compare the two. And some of the other topics that are certainly of concern for us in that acute, subacute management, dysphagia, tremendous deficit after stroke. I would think that is so miserable for patients who are suffering with this after a stroke. The recommendation now includes pharyngeal electrical stimulation, PES. It can be beneficial to decrease the aspiration risk and also reduce the severity of dysphagia even after vent weaning. It can actually help. There's actually some benefit in reducing the time to decannulate even after they acquire a tracheostomy. So this PES, many of us are very excited. I'm excited about anything that will help a patient be able to swallow. So again, looking at what we can do in the acute and even in the subacute phase of this treatment. The question that is often asked is, when can we start the PES? And I think that's an ongoing conversation as well. For in atrial fibrillation, the question always was, when can we start? When can we start an oral anticoagulation? So at mild severity, I don't think there's much controversy. Early oral anticoagulation is reasonable and non-inferior to delayed anticoagulation. So again, starting that earlier in those mild severity acute ischemic stroke patients. When we talk about mobility, again, this particular guideline reiterated the outcomes of the AVERT trial and other meta-analyses related to high dose, very early mobility defined within 24 hours with less favorable outcomes. And so again, when you have a trial that says something is harmful, something has less favorable outcomes, you really need to think about any other quality improvement initiatives that sort of go counter to that. Again, we have some more information that is undergoing in progress in terms of what is the dose of the mobility, what is the timing of the mobility, what is the frequency of the mobility, and so forth, and looking at are there some dosing sort of dichotomies that we can identify. And so more to follow on that. That information is not out yet, but I know that some of the same investigators that were participating in the AVERT trial are doing some of that for us. In addition to guidelines, we always have trials that come out, and these are not all of them, but these are a few of them. The Oceanic stroke trial came out. Asundexian, which is the factor XIa inhibitor, reduced the occurrence of ischemic stroke in patients with non-cardioembolic stroke or high risk of TIA on antiplatelet therapy without increase in major bleeding. So it's pending approval by the FDA. CREST-2 came out in patients with asymptomatic high-grade stenosis. Stenting plus intensive medical management demonstrated lower risk of stroke compared to intensive medical management alone. The carotid endarterectomy demonstrated no added benefit to the intensive medical management. And if you remember, the original CREST actually looked at sort of intensive medical management and then these interventions. And so CREST-2 looked at the interventions in addition to the intensive medical management, which I thought was a smart thing to do. The OPTION trial, TNK administered between 4.5 to 24 hours in non-large vessel occlusion stroke in patients who had evidence of penumbra on perfusion imaging had improved functional outcomes compared to standard medical treatment. Of course, they had some increased incidence of symptomatic ICH along with that. And then you have the FASTEST trial, the ultra-early factor XIa medication reduced the hematoma expansion by approximately 3 to 5 mils, but it did not improve functional outcome. And so those are some of the major trials that I think affect sort of some of our practices. So the question for you is, in terms of new guidelines, what is the challenge in these new guidelines for you as a program director, manager, or as an advanced practice provider, as a clinician at the bedside? Is it destination management? Is it blood pressure control after thrombectomy? What do we do with that? How about stroke unit development? Now, what do we do with that recommendation if you do not have a sort of a designated stroke unit? The extended window for thrombolytics. I mean, I always think that's exciting for organizations and facilities that can that can really look at that and make a leap forward in trying to push the envelope on treating these patients. Again, head of bed positioning and large vessel occlusion patients, many of us have changed that, but I just wanted to give you a little bit of that background. Are there other challenges that you find in the guidelines? When I look back at the 2018 guidelines versus these guidelines, I really appreciated the clarity in the language. I think the language was in many cases clearer. Okay, these are my references. And I did want to leave some time for conversation or questions.
Yeah, we have a
Lisa,
question in the chat.
oh my goodness, I hope I can answer it.
So it's actually a really good question, and it's one for good conversation. Who should be responsible for calculating the aspect score? Not every provider has the skill to do that. Well, this is true. The aspect score should be ideally calculated by clinicians trained to interpret stroke CT imaging, like your neuroradiologist, your neurointerventionalist, your APP provider who's been appropriately trained to do so. The AI platforms have kind of limited the ability of our providers to have constant exposure to calculating a manual aspect score. So truly, if you have somebody who's been around for a while, like in the ED, who's good at reading that, your neurorad, if you use Viz, I used to work with a neuroradiologist who would put the aspect score of the non-con into Viz right away. So those are things that you could develop. And please, Rhonda, comments about that.
Yeah. So yeah, I agree. I think AI has sort of made us a little lazy. I think, and it made us a little bit lazy. And I think mainly to keep the competency of how you do that. I wonder if when we're doing our M&Ms or if we're doing, that we do some fun games, hey, calculate an aspect score and
Compare.
You know what I mean? And compare it. It may be that that might be something that you do some quality assurance around. Is this is what my AI, we actually use Rapid AI and we've got it integrated in Pulsara. But sort of having a quality assurance where you can validate that they know how to do it, especially if the technology, for whatever reason goes down. Now, what do you do?
Right. Yeah, because back in the day, the aspect score was the way to calculate a mechanical thrombectomy patient until the
back
AI
in the day, we remember.
Yeah, exactly.
Well, and right, and in some organizations, that's really all you need. You need a non-con head CT, an aspect score, and you need, that is eligible and is suggestive, positive BVAS, positive VAN, that kind of thing.
Yes, I work with a neurointerventionalist who says he doesn't need the AI. He's got the real AI. Just show me the non-con.
Yeah, exactly. So I do think it's challenging. I do think that AI, but I think if you can sort of validate your AI and that you're getting good quality, but again, I think I think that is a skill that we are at risk for losing, to be honest, because we've just given it over to AI. And so, I'd be interested. Is there anybody else in the chat who's got some ideas about that?
Nope, just that one question.
Okay, I think it's a good question.
Oh, and I'm sorry, Morgan would like the slides for reference to look back at while reviewing the new guidelines.
Oh, perfect. Yes. Yep. I'm happy to send those. What about, let me ask you about blood pressure control. Are people after thrombectomy, especially when you get a high grade reperfusion, 2B, 2C, 3 reperfusion, are you just saying, hey, we're going to go for 140 to 160? We're not going to go below 140? What are you doing in your shop, Lisa?
We do, he used to do under 140. And I think sometimes the comorbidities play a factor. And especially, we go into it thinking that we're going to be less than 140 coming out. But a lot of times some of the findings that are patient specific tell him, let's keep it more 140, 160.
Yeah.
So, because he is worried about that reperfusion injury. It's such a fine line and window, and it can sometimes be very patient specific. And of course, if they're a little dehydrated to begin with, like our patient yesterday, and to give her a little bolus in the lab. And then we went from wanting to be under 140 to being in the 140 to 160 range. So.
Gotcha. Yeah. So what about stroke unit development? We have a well-organized stroke unit. We have a designated stroke unit that is designated for all of our stroke patients. But,
Yeah.
I just wondered if that sort of was going to kind of force the United States to sort of come around to where Europe is.
It would be nice, wouldn't it? I've worked at two facilities in the last year. This past year, I've been at one facility, and just prior to that, I was at another. Both facilities had stroke units. They were med surg units. In one, the stroke responders for for the stroke alerts played overhead. Those
Yeah,
charge nurses were part of the stroke response team. In my current facility, the rapid responder nurses are part of that stroke team.
yep,
So they have a stroke unit, and they take like the critical, non-procedural cases. They will recover our stroke, like our diagnostic cerebrals, but
yeah, yeah,
there's such a great benefit to having a stroke unit. And when without, like our numbers as far as the get with the guidelines are
yeah,
very high.
yeah.
Of course, minus the dysphagia screen. I don't want to brag, but
Well, that's a challenge for all of us, Lisa. You just made us
yeah.
feel better about ourselves.
Good.
Yeah. Anything else in the chat?
Yes. How do stroke units come into play with those post cardiac patients? I
Yeah.
mean,
So here's what I would tell you. I would tell you that, and some of the people can comment in the chat as well. I will tell you, and we use a lot more ICU
mhm,
for post-procedure patients than
we do
probably
too.
than anyone else in the world. We're heavily ICU. Other places in the world, they recover their post procedures on stroke unit. They're very specialty trained, and that continuum of care for the stroke patient. And so that's they may have a step down unit that does that where the ratios may be a little bit
Yeah, that's what ours
less,
is.
a little bit less. We're not there yet. We still recover ours in the ICU. And so, but the United States as a rule is generally ICU dependent for that. And that's
Mhm.
not true around the world. So I think we're going in the direction where when you have a designated stroke unit and you have those designated nurses that see those patients, and you don't mix them in with respiratory, and you don't, I mean, you might have some overflow. I mean, let's be realistic, but you have a deeper knowledge of that patient population. I think that's going to give you more consistency in terms of your metrics and in terms of those outcomes. And that's what has been shown since the 1980s in Europe and
Yeah.
Norway and in the Scandinavian countries in particular.
You also get good depth in your bench, if you will, where you have
Yep,
more
yep,
people working towards the progress of that patient. So to Jill, to your question, the post cardiac, I'm not sure exactly what you mean by post cardiac, but there are a lot that we share. LV thrombus and a thrombectomy would be a good
yeah,
candidate for an ICU stroke unit because Rhonda, like you said, we have the same thing. While our
yeah,
diagnostics will go to the PCU stroke unit, the rest of our
yeah,
interventions go to the ICU. So there actually is a great advantage of taking this PCU nurse and having her follow with the first 12, 24 hours of that intervention that's going to the ICU so they can actually see and understand where the ICU ends and PCU begins and what kind of gap they can keep from that patient having to go back to the ICU or vice versa, the patient movement, because this happens a lot too.
yeah.
You know,
Because I think it's all about I think it's all about the education of the nurse and
mm,
making sure that bedside staff really understands number one, where's that patient been,
right.
and really the trajectory of the patient. So,
The
but I
cross
think that
training
there's
is
a
nice. I'm
yeah,
sorry to interrupt you.
yes,
Jill commented again. She said we do cross train, but have a separate CV ICU and stroke ICU, and that is appropriate. But there does need to be some good bleed between the two.
yeah,
I work in a
yeah,
procedural area now, and I can see a vast difference between my CV ICU nurse in the neuro IR and my neuro ICU nurse in the neuro
yeah,
IR. And just with
yeah,
the concept that they're able to grasp easily. Not saying that either is lacking. It's just you're in a pump framework when you're in the heart and
yeah,
it's different. There's
yeah.
a lot of different things, not to mention that post cardiac unit is also, I don't know if your facility does this, but mine does TAVRs and open hearts and things.
Hmm.
So they tend to be centered to that.
Yeah, yeah, but again, I think that I think the cross training between the two is really important because I always
Critical.
say every patient is a neuro patient.
Yeah. Yeah.
They go on and see me, yeah, every patient is a neuro patient.
You
That's what I
actually
tell them.
just mentioned something very important. I came across this on the socials. I don't know if any of you have seen, there's a redhead anesthesiologist, and she's putting out a neuro index where you take tests and, you know, we get EKGs for our heart. We get all of these different
Yeah.
studies done to make sure that we're safe to undergo anesthesia,
Yeah.
except
Yeah.
for our brain. And so she had actually
Yeah.
recently put out collecting evidence for her research to say, yes, we need to be assessing people's brains before we put them under anesthesia.
Yeah. Yeah.
So very
Good,
cool.
good for her. Good for her.
Yeah. I reached out to her.
So, okay. So Lisa, we do not
Man,
have how to operationalize the recommendations related to pediatric stroke. Do you guys do pediatric stroke, or do you
we do
send them to
not.
the children's hospital?
We do not.
So here's what I do think. I do know that there are, we do have members who have pediatric sort of services. And so what I would do is I would put that question out on the discussion board. So I would go to members only and put that question out on the discussion board, because we do have members, and we have previous board members that do take care of pediatric stroke, and I guarantee you they have some help for you.
Yep. And actually, I would recommend coming to the 2026 annual conference where this will be on our
Yeah,
program agenda.
that's right. Yeah.
Shameless
Yeah. I
plug.
mean, and pediatrics, the one thing that I would say about and I was so glad that they put such an extensive, I just found the clarity of the guidelines. I just thought I just thought the clarity was really good. And I also really enjoyed, if you can enjoy such things, I really enjoyed sort of the conversation, which really helped us understand why they were saying what they were saying. And I think it's really important when we're analytical about and not just sort of checking the box,
Mm-hmm.
especially as we deal with head of bed positioning for large vessel occlusion. You know, that discussion after that guideline was so important to help us understand that, you know what,
Right.
we have a specific patient population that wasn't able to be in the guideline. And so what's the right thing to do
Right.
when you really have a specific patient population versus, you know, sort of a heterogeneous population with hemorrhage and large vessel and small vessel occlusion, that kind of stuff.
Yes.
Yeah.
Love this.
Lisa,
Great
what stood
talk.
out to you? Yeah, yeah. What stood out to you in the guidelines? Anything from interventional, like MEVOs, anything that stood out that you?
Not really. I was actually more interested, and this is partially personal work that I do on the side with the Arizona State rural and tribal EMS community. Phoenix
Yeah,
Fire recently went on bypass protocol, so they are bypassing primary centers to take their code LVOs, and we use the VAN protocol to the comprehensive or thrombectomy capable. So I'm particularly interested in this so that I can help guide my rural and EMS people
yeah.
to understand how to treat some of these in the early, because they're out far. They're up far.
Well,
And
and
essentially,
so
I think this is
yeah.
kind of similar for southeast
Mhm,
of the United States. You've got, and
mhm.
Houston, you've got these great big centers, but then 5, 10 miles out of town, desolate. So
Right, and tough to get them in, you
yeah,
know, and
yeah,
tough to get them in, and tough to get a unified protocol
yes,
around when you're dealing with dozens of EMS, dozens of medical
yes.
directors, you know, all of that kind of stuff.
I actually
I
started
do,
with, sorry, go
yeah.
ahead. Well, I was going to say, I started
Well,
with my doctorate a few years ago, training Phoenix Fire to the VAN protocol. So,
yeah,
and I worked with the Phoenix, one of the police chiefs, the medical director of the Phoenix Fire, to
yeah,
teach his people VAN and to help them get set up towards this end goal.
yeah, yeah.
It's a
Well,
lot of work.
yeah, well, it is hard work. I think it's strong work, and I also think that the option for destination management, depending on where you are. And I thought that was really important language
Yes.
that sort of gave permission, even though we've had scientific statements, it really sort of gave permission to go, okay, this is where you are. This is where you are locally. And now you have to really look at the options to take care of your community of patients.
Yes. I love that too.
So anyway, I mean, I think the authors, I do want to say that the stroke clinician, the spring issue will be out probably relatively soon. And so I do have sort of more of comment on living guidelines versus static guidelines, because wouldn't it be wonderful if we just had a little bit at a time? I just throw that out there for consideration because Australia has done it and they are doing it. So, we can, we don't have to be the first. We
Yes,
can, other people
well,
have done it before us. That's
that's
right.
right.
That's right. Listen, I appreciate all of you coming. If you would put the comments on the pediatric stroke, put those on the discussion forum because I think you're going to get some good feedback from that. And if we want to also put the comment in terms of how the stroke units sort of interplay with the post-cardiac patients if they are sort of unified unit. I think put that question out there and see if someone has
Yeah, I'd
some
be curious too.
combined units. I'd be curious about that.
This
I would be.
this work this job that I'm in now, it's interventional radiology, but we touch so many patients, especially cardiac, because we're right next door to cardiac cath lab. And brain
Yeah,
always talks about what we learn from the heart. However, there are so many things that they do with the heart in this facility that, wow,
yeah, I
that's a
know.
that's a
Yeah,
lot that we
it's a
could.
lot.
It's a lot.
It
So
it is. It
I'm
is. And
curious.
we have sort of the same thing with a neuro ICU and a different CV ICU. I just need them when they need to be able to talk to each other.
Yes,
Because like I tell them, everyone is a neuro patient.
I love that. I'm gonna steal that bumper sticker.
All right,
All
listen,
right.
thank you so much, everybody. I
Have a
appreciate
great
all of you.
day.
I hope you have a good rest of your day. Lisa, I enjoyed
Always.
sharing the stage with you.
Always. Mwah.
All
Have a
all
great
right,
day, everyone.
all right, you too. Thanks so much.
Bye.
Bye-bye.